The deeply ingrained belief for many is that when a surgeon proposes an operation, it must inherently be the correct path, an unquestionable directive from an expert who knows best, with the hospital providing all necessary equipment and paperwork ready for a mere signature. This trust, a default comfort in deferring to medical authority, was once my own perspective, until I began a disquieting practice, meticulously counting the individuals who underwent what were described as routine procedures, only to emerge from the operating room profoundly and permanently altered, not necessarily better, but irrevocably changed. I witnessed the stark reality of a man entering the hospital with persistent back pain, leaving entirely unable to walk, his life dramatically reshaped by the very intervention meant to provide relief. Similarly, I observed a woman who, despite surviving complex open-heart surgery, subsequently endured 6 agonizing months of debilitating complications, a labyrinth of unforeseen challenges that nobody had prepared her for. It is a critical truth that often goes unsaid. The older a body becomes, the more strenuously it must fight simply to withstand the physiological assault of an operation itself, distinct from the battle against the underlying disease. As Dr. Mandel, my commitment today is to illuminate the often obscured realities of 5 specific surgeries that pose serious, hidden risks, particularly to individuals navigating life over the age of 60. Before delving into these crucial details, I must underscore a fundamental principle that underpins all subsequent information. If you find yourself over 60 or sensing its imminent approach, and your profound desire is to cultivate a life of sustained longevity, strength, and vibrant health, retaining the precious independence to make your own choices for many years ahead, then a brief moment of your attention now is invaluable. I have meticulously distilled the comprehensive guidance I provide to my private patients into a clear, actionable plan that has already empowered thousands to live their most fulfilling lives after 60, a resource conveniently accessible for your consideration once our discussion concludes. Should this video empower you with greater clarity, I humbly ask for a small favor. Consider subscribing, liking, and leaving a comment, as these simple actions significantly expand the reach of this vital information to others who desperately need to hear it. Reflect for a moment on the fundamental difference between a brand new automobile and one that has traversed over 200,000 miles. Subjecting both to an identical stress test would undoubtedly yield profoundly different outcomes. Yet, for many decades, the medical community frequently approached a 70-year-old body with the same surgical protocols, identical recovery expectations, and rigid timelines applied to a 40-year-old, a standardized methodology that failed to account for the unique vulnerabilities of aging. While this paradigm is gradually shifting, the pace of change remains alarmingly insufficient. The internal physiological response of an older body under the influence of general anesthesia is a complex cascade of events. The heart is compelled to labor with increased intensity, the lungs require a significantly longer duration to effectively metabolize and clear the anesthetic agents, and the kidney's capacity to process medications slows markedly. Perhaps most surprisingly to many, the brain experiences a temporary disorientation, a condition clinically termed post-operative cognitive dysfunction, POCD, which can unfortunately persist for weeks or even months. Among patients age 70 and above, the incidence of POCD is far more prevalent than is commonly acknowledged or discussed. It is vital to emphasize that age, in and of itself, should not be the sole determinant for avoiding surgery. Indeed, I have personally observed 80-year-olds who recover with a vitality surpassing that of some 50-year-olds. While age can often be perceived as merely a number, frailty is unequivocally a medical reality, a clinically defined term signifying that the body's physiological reserve has diminished below a critical threshold. Studies indicate that approximately 40% of individuals over 75 exhibit signs of frailty, a figure that escalates to nearly 60% among those over 85. Therefore, the truly pivotal inquiry is not merely whether a person can survive the immediate operation, but rather whether they possess the resilience to navigate and recover from the demanding post-operative period. Two distinct challenges with vastly different implications that demand careful consideration. The first category of concern involves open heart surgery in frail patients. Procedures such as coronary artery bypass grafting, CABG, commonly referred to as bypass surgery, represent one of the most frequently performed major surgeries on older adults. The underlying principle is elegantly straightforward. Blocked arteries are rerouted to restore proper blood flow, and for the appropriately selected patient, the results can be remarkably life-changing. However, what is often omitted from the simplified explanations is the profound physiological stress this procedure entails. Open heart surgery necessitates the complete cessation of the heart, with the patient relying entirely on a cardiopulmonary bypass machine, an external device that temporarily assumes the vital functions of both the heart and lungs during the surgical intervention. For a 60-year-old in robust health, this temporary reliance is generally manageable, yet for a 78-year-old contending with coexisting conditions such as kidney disease, mild diabetes, and emerging cognitive decline, this bypass machine represents a severe and simultaneous assault on virtually every organ system in the body. Research consistently demonstrates that in frail elderly patients, open heart surgery carries a substantial 30 to 40% risk of major complications, encompassing events like stroke, acute kidney failure, prolonged periods of confusion, and extended dependence on mechanical ventilation. Furthermore, a sobering statistic that often brings people to a halt is the fact that up to 15% of high-risk elderly patients may not survive the initial 30 days following this complex surgery. The critical question then arises, what are the alternatives? In a growing number of cases today, innovative, less invasive options exist, such as transcatheter aortic valve implantation, TAVR, a catheter-based procedure that meticulously replaces a diseased heart valve without requiring the heart to be stopped or the chest to be surgically opened. This approach is far less dramatic and significantly kinder to an aging body, offering a gentle solution rather than a profound battle. This does not, however, suggest that one should categorically refuse necessary heart surgery. Instead, it underscores the absolute necessity of asking your surgeon a pivotal question: am I a candidate for a less invasive approach? This single inquiry holds the potential to fundamentally alter your medical trajectory. Secondly, aggressive spinal surgery warrants careful scrutiny. Back pain, a ubiquitous complaint, affects virtually every patient over 70 I have ever encountered. Increasingly, the proposed solution is extensive spinal surgery, often involving fusions, multi-level decompressions, and the insertion of complex hardware along the spinal column. To be unequivocally clear, certain spinal surgeries are undeniably medically necessary, particularly in acute situations where the spinal cord is actively compressed, leading to symptoms like loss of bladder control or paralysis, which demand immediate surgical intervention. However, when it comes to elective spinal fusion for chronic degenerative back pain in an elderly patient, the medical evidence is genuinely troubling. A significant study published in the esteemed journal Spine revealed that among patients over 65, complex spinal fusion procedures were associated with a complication rate exceeding 40%. These were not minor complications, but often included serious issues such as blood clots, deep-seated infections, failure of the implanted hardware, and a phenomenon known as adjacent segment disease, where the vertebrae immediately above and below the fused section begin to degenerate more rapidly due to the altered biomechanics of the spine. The hardware rigidly stabilizes one segment, effectively transferring increased stress and strain to the adjacent segments, which then bear the brunt of the compensation. What I find most profoundly frustrating is the often limited efficacy regarding pain relief. Numerous studies indicate that for many elderly patients suffering from degenerative spinal conditions, aggressive surgical intervention provides no superior long-term pain relief compared to more conservative approaches like dedicated physical therapy and precisely targeted injections. The outcome is often no better, but the risks are dramatically higher. A brilliant spine surgeon colleague once shared a profound insight with me. Sometimes the best operation is the one you don't do. This wisdom resonates deeply and frequently guides my own clinical judgment. It makes me wonder how many individuals have been told that surgery was their sole recourse for back pain. Thirdly, major cancer resections represent an emotionally charged area that demands exceptional sensitivity. Upon hearing the word cancer, the immediate, powerful, and utterly understandable human instinct is to eliminate it, to cut it out, remove it, get rid of it. I comprehend this visceral reaction entirely, as I would feel the same way. However, 2 decades spent immersed in surgical practice have instilled in me a crucial realization. The ultimate goal of cancer treatment extends beyond merely excising the tumor. It is to afford the patient more years of quality life. And sometimes, not always, but in specific instances, major surgical intervention in a frail elderly patient regrettably achieves the antithesis of this goal. Consider the poignant example of pancreatic cancer surgery, specifically the Whipple procedure, which stands as one of the most intricately complex operations in all of medicine. This extensive procedure involves the removal of the head of the pancreas, a segment of the small intestine, the gallbladder, and a portion of the bile duct, typically requiring 6 to 10 hours of meticulous surgical effort. While it can be genuinely life-saving for younger, otherwise healthy patients, its implications for an 80-year-old with pre-existing heart disease and reduced kidney function are vastly different. In such a scenario, the surgery might technically succeed in removing the tumor, yet the patient tragically succumbs to surgical complications within weeks, not from the cancer itself, but from the immense physiological toll of the operation. This grim outcome is termed futile surgery, and its occurrence is far more common than anyone is willing to concede. A landmark study from the American College of Surgeons disturbingly found that nearly 1 in 5 elderly cancer patients who underwent resection experienced failure to rescue, meaning a serious complication arose that their weakened body simply lacked the physiological reserves to overcome. Therefore, a vital conversation to initiate with your oncologist, directly and without hesitation, is this. If we opt against surgery, what do watchful waiting, radiation therapy, or targeted therapy approaches entail for someone of my age and current health status? This inquiry can open a door to alternative strategies that many patients were never even aware existed, and occasionally, the answer revealed behind that door is genuinely superior for preserving both life and its quality. Fourth, elective joint replacement in severely ill patients presents a nuanced challenge. Hip and knee replacements are widely celebrated as among the most successful surgical advancements in modern medicine, a statement I make without reservation. For the appropriately selected patient, a new hip or knee can genuinely revolutionize their quality of life, transforming individuals who could barely walk into active participants capable of playing with their grandchildren. The term elective is key here. It signifies that the surgery is planned, not an emergency, affording precious time for contemplation, thorough preparation, and critically, the opportunity to ascertain if this particular moment is optimal for your unique physiological state. The statistics reveal a crucial caveat. In patients over 75 with 3 or more significant health conditions, such as heart disease, diabetes, chronic kidney disease, or obesity, elective joint replacement carries a significantly elevated risk of perioperative complications. Among these, blood clots pose the greatest danger, with deep vein thrombosis (DVT) in the legs, potentially leading to life-threatening pulmonary embolisms if they travel to the lungs. In elderly patients with already compromised circulation, this risk is substantially higher than in younger cohorts. Compounding this are risks such as post-operative pneumonia, often exacerbated by prolonged immobility, and the ever-present threat of hospital-acquired infections, collectively painting a far more intricate picture. My intention here is to be precise, not to unduly alarm individuals who could genuinely benefit from these procedures. The question is not whether one should ever undergo a joint replacement, but rather, is my body currently in the optimal condition for this surgery? Meticulously optimizing blood pressure, blood sugar levels, body weight, and overall cardiovascular health prior to an elective surgery can dramatically reduce complication rates. Recognizing this, some leading hospitals now mandate formal prehabilitation programs for high-risk elderly patients before scheduling these operations, an unequivocally correct and proactive approach. Many patients remain unaware of the concept of prehabilitation, yet it is a conversation that absolutely should occur with their doctor before any planned surgery. Finally, emergency abdominal surgery, a category distinct from the others, commands immediate attention. This is not a procedure one chooses, rather, it imposes itself upon you without warning. Conditions like a perforated bowel, a ruptured appendix, or internal bleeding do not permit the luxury of calm, measured office discussions. However, its inclusion on this critical list is paramount because knowing the inherent risks in advance before such an emergency erupts can profoundly influence how families make agonizing decisions in those terrifying, time-sensitive moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates across all surgical disciplines, often ranging from 30% to a harrowing 50% in the most severe cases. This is not a reflection of surgeon incompetence, but rather the stark reality that an elderly body subjected to sudden acute trauma is simultaneously battling on far too many physiological fronts. The liver, kidneys, heart, and lungs are all simultaneously impacted, and the inflammatory response that a younger, more resilient body typically controls within days can, in an older body, spiral into a devastating condition known as systemic inflammatory response syndrome, SIRS. When multiple vital organs sequentially begin to fail, the prognosis is as dire as it sounds. So, what concrete actions can be taken with this chilling information? 2 critical steps. First, never ignore abdominal symptoms. Persistent pain, unexplained bloating, or any significant changes in bowel habits in an individual over 60 demand immediate and thorough medical attention. Catching problems in their nascent stages often means they can be addressed before escalating into life-threatening emergencies, a single habit that can indeed alter everything. Second, initiate these difficult conversations with your family now, not in a chaotic hospital corridor at midnight. Articulate your wishes explicitly regarding emergency surgery. What quality of life is truly paramount to you? These dialogues, far from being morbid, are among the most profound expressions of love and care you can offer to those who will ultimately bear the burden of making decisions on your behalf during moments of crisis. Having navigated these 5 surgical scenarios, let us now transform this knowledge into decisive action, for information without implementation merely fuels anxiety, which is the very antithesis of my purpose for you. Prior to any significant surgery, whether planned or merely recommended, every patient over 60 must pose 4 fundamental questions. I urge you to commit these to memory. Question 1. What unequivocally happens if I don't have this surgery? A conscientious surgeon will provide a transparent and candid assessment. If the honest answer indicates that no urgent or irreversible changes are anticipated within the next 6 to 12 months, then you possess the invaluable gift of time. Time to reflect, to seek a second expert opinion, and crucially, to optimize your overall health in preparation. Question 2. Is there a less invasive alternative available? Medical science has undergone an extraordinary evolution over the past 15 years, giving rise to sophisticated options such as robotic surgery, advanced endoscopic procedures, and innovative catheter-based interventions. Solutions that were inconceivable a decade ago are now routinely offered in most major medical centers. Question 3. What does recovery realistically entail for someone of my specific age and unique health profile? The answer should not be a generic overview applicable to the average patient, but rather a highly personalized projection tailored to your individual heart function, kidney health, current medication regimen, and living situation. Specificity here is paramount, not broad generalizations. And finally, question 4, the one most patients regrettably overlook. What is your personal complication rate for this particular procedure in patients over 70? Proficient surgeons meticulously track these statistics. They are intimately aware of their numbers. A confident, ethical surgeon will readily share this information. If, however, they appear uncomfortable or defensive when confronted with this direct inquiry, that reaction itself constitutes valuable information for your decision-making process. Beyond these crucial questions, I want to impart knowledge rarely shared with patients, yet capable of influencing your surgical odds more profoundly than almost anything that transpires within the operating room itself. Should you ultimately determine that surgery is indeed the correct choice for you, the actions you undertake in the critical 2 to 4 weeks leading up to the procedure are immensely consequential. While surgeons dedicate years to perfecting their craft, very few patients are guided to spend even 2 weeks adequately preparing their body to survive the monumental physiological challenge ahead. Let us rectify this oversight. The first pivotal element, which we briefly touched upon, is prehabilitation. This concept is essentially structured training for an athletic event because, make no mistake, surgery is precisely that, a profound metabolic and physical marathon your body is about to endure while you are asleep. Thus, in the weeks preceding the operation, you must diligently build your physiological reserve. This involves consciously increasing your protein intake, as protein is the essential building block your body utilizes to repair and rebuild tissues, a nutrient many individuals over 60 often unknowingly underconsume. It also means engaging in daily physical activity, even if it is just a brief walk around the block, because the stronger your leg muscles and lung capacity are going into surgery, the more rapidly you will be able to get up and move afterward. Early ambulation is a cornerstone in preventing the very blood clots and pneumonia complications I previously highlighted. Furthermore, if you are a smoker, even a cessation of just 2 weeks before surgery demonstrably lowers your risk of wound and lung-related complications. A mere 2 weeks. That is all it takes. I have personally witnessed the transformative power of prehabilitation, turning a patient initially classified as high risk into one undergoing a routine procedure, all achieved through effort rather than financial cost. The second critical conversation, one that is almost universally neglected, is with your anesthesiologist. Recall the brain fog I mentioned, post-operative cognitive dysfunction? There are tangible, practical strategies that significantly reduce its likelihood. Request a preoperative anesthesia consultation. Bring a comprehensive, exhaustive list of every single medication and supplement you consume, and I mean every one, including seemingly innocuous items like fish oil or herbal sleep aids, as some of these can interact with anesthetic agents in ways that frequently surprise even seasoned professionals. Inquire whether a regional or spinal anesthetic, which numbs only the specific surgical area without inducing full general anesthesia for the entire brain, is a viable option for your particular procedure. For many hip and knee operations, this is indeed a possibility and is often considerably gentler on an older brain. And here is a seemingly minor detail that often sounds too simple to matter, yet yields profound benefits. If you utilize hearing aids or eyeglasses, explicitly request that they remain with you until the very moment you drift into unconsciousness and are promptly returned the moment you awaken. Patients who can immediately see and hear their surroundings upon regaining consciousness experience confusion far less frequently, a fact unequivocally supported by research on hospital delirium, and it is entirely free. The third crucial piece of this preparatory puzzle is the home recovery setup, a detail almost everyone overlooks until they are actively living through it. Arrange for your post-surgical support before the operation, not in the chaotic aftermath. Clearly establish who will drive you home, who will stay with you during the critical first few nights, and importantly, where your bed will be located. Minimizing the number of stairs you must navigate in the first week significantly aids recovery. Proactively clear any potential tripping hazards, such as rugs and loose cords. Ensure all necessary prescriptions are filled in advance, sparing a tired family member a late-night trip to the pharmacy. The initial 72 hours after returning home are instrumental in setting the trajectory for the entire recovery period, and a body that is not simultaneously battling a fall or a missed medication regimen will undoubtedly heal more efficiently. Also, diligently watch for warning signs during those critical first days. Sudden or increased confusion, a persistent fever, or a calf that becomes swollen, hot, or painful. Any of these symptoms warrant an immediate call to your medical team. Do not delay. The fourth and perhaps most vital piece of advice is to absolutely obtain a second opinion. I understand this often feels awkward, as patients frequently worry about offending their surgeon. Let me unequivocally put that worry to rest right now. A truly competent ethical surgeon anticipates and welcomes a request for a second opinion, viewing it as a testament to diligent patient advocacy, and would expect nothing less for their own loved ones. Ensure you bring all your diagnostic scans and medical records so that the second physician is evaluating the exact same clinical picture. If two highly qualified surgeons, examining the identical body and images, arrive at divergent recommendations, this is not a problem, but rather invaluable information. This is precisely the kind of comprehensive insight you deserve to possess before anyone contemplates picking up a scalpel. None of this counsel is intended to instill fear. Rather, its purpose is to empower you to approach surgery prepared and informed, rather than merely hopeful. The patient who walks in strong, knowledgeable, and organized represents a fundamentally different surgical risk profile than one who arrives frightened and underprepared, even if the operation itself is identical. You possess significantly more control over which of these two individuals you will be than anyone has ever conveyed to you. There is one further crucial piece of guidance I must offer, which may prove to be the most practical of all, focusing on how to interpret the surgical recommendation itself. Over my years of practice, I have come to recognize that the manner in which a surgery is presented to you often reveals almost as much as the surgical procedure itself. Therefore, be acutely aware of these 5 warning signs or red flags. When you encounter them, it is imperative to slow down and exercise caution. The first red flag is speed, feeling rushed into a decision with phrases like, "We need to get you on the schedule right away." While internal bleeding or other acute, life-threatening situations absolutely demand swift action, true urgency for a planned elective operation is remarkably rare, and a genuine professional understands this distinction. If a knee that has caused pain for a decade suddenly must be replaced this month, demand to know the specific rationale for this accelerated timeline. Pressure to decide quickly is almost invariably driven by scheduling logistics or other factors, rarely by your actual physiological needs. The second red flag is a single path, being presented with precisely one option, surgery, with no mention of any alternatives whatsoever. Remember, by the time you reach 70, there is almost always a multitude of potential roads to consider. Medication management, targeted physical therapy, localized injections, a strategy of watchful waiting, or even a less invasive version of the very same procedure. If none of these possibilities are even introduced into the conversation, it is not because they do not exist, but because they have deliberately not been placed on the table for your consideration. The third red flag, one that people frequently miss entirely, is the complete omission of the do nothing for now option from the discussion. Actively doing nothing, which in medical terms translates to careful monitoring and conservative treatment, is a perfectly legitimate and often highly appropriate medical choice. For many conditions affecting older adults, it is, in fact, the most judicious, Course of action. If your surgeon cannot or will not clearly articulate what the likely outcomes would be if you simply wait and monitor your condition, then you fundamentally lack sufficient information to provide truly informed consent for any intervention. The fourth red flag pertains to how your challenging questions are received. If you pose a difficult inquiry, what is your personal complication rate? What are my alternatives? What happens if I wait? And instead of a direct, honest answer, you receive a dismissive brush-off or a defensive reaction, pay close attention. A good surgeon will never become defensive when asked the very questions they would pose if it were their own family member. If your questions create tension in the room, that tension is a powerful indicator, revealing something significant about the situation. And the fifth red flag is a recovery plan that is glossed over with vague platitudes like, "Oh, you'll be back on your feet in no time." This is not a comprehensive recovery strategy, it is a sales pitch. An honest, realistic description of recovery sounds vastly different. It details, here's what week 1 will look like. Here's precisely when you will require help at home. Here's the part that will be genuinely challenging. Here's what specific warning signs we will be diligently watching for. Specificity in these discussions is a hallmark of respect for the patient. Vagueness, particularly cheerful vagueness, is often a sign that someone is attempting to manage your emotions rather than genuinely inform your critical decision. I wish to state something with careful precision here, as it carries significant weight. None of this implies that your surgeon is inherently a bad person. The overwhelming majority of medical professionals enter this field with a sincere desire to help, and they labor with brutal dedication. However, it is also crucial to comprehend the intricate system within which they operate, a system often structurally built around performing procedures, financially rewarding the execution of procedures, and rigidly constrained by brief, often 12-minute appointments that simply do not afford the luxury of comprehensively exploring 5 alternative treatment paths. Therefore, the inherent bias toward active intervention is typically not a personal failing, but a structural one. And the most reliable mechanism for effectively cutting through such a pervasive structural bias is an empowered, informed patient seated across the desk, articulately voicing these critical questions aloud. So, what then does truly good medical practice look like in this context? Let me delineate it so you can unequivocally recognize it when you encounter it. A truly beneficial surgical consultation deliberately slows down. The surgeon takes the time to thoroughly explain the medical problem to you, often physically sketching diagrams on paper to enhance clarity. They proactively name potential risks without you having to prompt them. They spontaneously inform you of viable alternatives and what the implications of a wait-and-see approach might be. And the very best among them will utter the reassuring words you hope to hear. If you desire a second opinion, I believe that is an excellent idea, and here is a respected colleague I would personally send my own mother to consult. When you hear such an affirmation, you have unequivocally found a professional worthy of your trust. Hold on to them. One final yet profoundly impactful piece of advice: never attend a major surgical consultation alone. Bring a trusted companion with you, a spouse, an adult child, or a close friend. The reason this matters more than people typically imagine is something I have observed countless times over 15 years of clinical practice. The instant a patient hears a frightening word, cancer, surgery, blockage, a kind of protective fog descends. The mind instinctively retreats to the worst possible scenarios, and from that moment onward, they often absorb very little of what the doctor subsequently says. Later, in the car ride home, they are frequently unable to accurately recount even half of what was discussed. This phenomenon has nothing whatsoever to do with intelligence. It is simply a fundamental physiological response, what acute fear does to the human brain. Therefore, ensure you have a second set of calm, objective ears in the room. someone who is not the direct recipient of potentially terrifying news, and who can therefore genuinely listen with clarity. Have this person take meticulous notes, or, with the doctor's explicit permission, record the entire conversation on a smartphone so you can calmly review it at home later. Crucially, brief this companion beforehand on the precise questions you want asked. The 4 essential questions: the exploration of alternatives, the realistic recovery expectations, the complication rates, so that if that protective fog descends upon you, they can effectively advocate on your behalf. A frightened patient and a clear-headed advocate working in concert will invariably make far superior decisions together than either could possibly make alone. Do not embark upon the biggest medical decision of your life by yourself when there is absolutely no need to do so. Before concluding with the most impactful message of all, I wish to imbue this discussion with a genuine sense of hope, for this is not a video designed to incite fear, but rather to illuminate the power of options. Options that have never been more advanced or more empowering than they are today. The advent of minimally invasive surgery has utterly transformed what is possible for elderly patients. Laparoscopic procedures, characterized by small incisions and camera-guided precision, dramatically reduce recovery times and postoperative pain. Robotic-assisted surgery offers an unparalleled level of precision, performing maneuvers that human hands alone simply cannot achieve. Furthermore, sophisticated catheter-based cardiac interventions have opened vital doors for patients who would never have been deemed suitable for or capable of surviving traditional open-heart surgery. Beyond surgical innovation itself, and this is a message I profoundly wish more patients fully grasped, optimized medical management represents a genuinely potent force. The careful, tailored combination of appropriate medications, diligently supervised physical therapy, precisely targeted injections, and comprehensive nutritional support can effectively manage many conditions that, in previous eras, seem to inevitably demand surgical intervention. The human body inherently possesses a remarkable capacity for healing. Sometimes our role as surgeons is simply to remove obstacles and judiciously provide the necessary tools to facilitate its innate restorative processes. Allow me to share a particularly illustrative patient story, a gentleman I refer to as Gerald. He was a 71-year-old retired engineer, possessing a keen intellect and sharp wit. Gerald presented to me after having received recommendations for open-heart surgery from 3 distinct surgeons, each delivering the same, unequivocal answer for his blocked coronary artery. Yet, Gerald's concern wasn't fear of the surgery itself. It was a profound dread of losing his essence, of undergoing a transformation similar to what he had witnessed in his wife 2 years prior. After her major operation, she had emerged from the hospital profoundly confused, perpetually exhausted, and, in his poignant words, never quite the same. His heartfelt confession, "Dr. Mandel, she went in as my wife and came out as someone I had to take care of," has remained indelibly etched in my memory ever since. When I meticulously reviewed Gerald's comprehensive medical profile, his precise kidney function, his quantified frailty score, his cognitive baseline, I spent an unhurried 40 minutes with him, not the typical hurried 15, and presented him with the unvarnished truth. While surgery certainly remained a viable option, an equally compelling alternative existed: an aggressive medication protocol synergistically combined with a structured cardiac rehabilitation program. The robust data for his specific clinical profile demonstrated comparable 5-year outcomes between the 2 distinct approaches. Unsurprisingly, Gerald, armed with this complete information, chose the non-surgical path. That pivotal decision was made 4 years ago. Just last month, I received a photograph from him. It captured Gerald, standing triumphantly at the summit of a challenging hiking trail in Colorado, flanked by his 2 granddaughters, now both taller than him, a radiant grin on his face, beaming as if he had just won the lottery. Here is the single most important message I will impart today, the essence of everything we have discussed. A surgical recommendation is fundamentally not a verdict. It is merely the commencement of a critically important conversation. You are not a passive recipient of medical decisions. You are an empowered, active participant in your own healthcare journey. The very moment you step into a surgeon's office, you possess the unequivocal right to ask every challenging question, to earnestly request the exploration of every alternative, and to take every single day you need to make an informed choice. While the surgeon holds the scalpel, it is you who ultimately holds the profound power of choice. And that choice, forged with comprehensive information and viewed through clear, discerning eyes, is by far the most potent instrument in all of medicine, more powerful than any operation I have ever had the privilege to perform. To consolidate our understanding, let's briefly summarize the 5 categories of surgeries that warrant particular caution for individuals over 60. Open heart surgery in frail patients, especially now that less invasive, equally effective alternatives often exist. Aggressive spinal fusion procedures, where the evidence for long-term pain relief is frequently far weaker than patients are typically led to believe. Major cancer resections, where the overarching goal must invariably be to maximize good years of life, not merely to remove a tumor at all costs. Elective joint replacement in severely ill patients, a domain where meticulous timing and diligent preoperative preparation are as crucial as the surgical skill itself. And finally, emergency abdominal surgery, where the most robust protection stems from the early recognition of symptoms and candid, proactive conversations with your family about end-of-life wishes. None of this comprehensive discussion implies that all surgery should be avoided. Surgery saves countless lives every single day. I have witnessed its miracles. I have been a proud participant in its triumphs, and I stand by its life-giving potential. The overarching message, crystal clear and unambiguous, is this: be an informed patient. Ask the difficult, probing questions. Insist on exploring all viable alternatives. Seek a second opinion, and if necessary, a third. Your age is not a weakness. It is a repository of life experience that merits thoughtful consideration. I encourage you to reflect. What single question would you most want to ask your surgeon before undergoing a major operation? If this video has helped you or someone you cherish to approach a surgical decision with greater clarity and confidence, I implore you to share it widely, as that single act could be the most important thing you do today. Please take diligent care of yourselves, remain perpetually curious, and relentlessly advocate for your own health. You unequivocally deserve a surgeon who patiently explains every aspect and a medical team that treats you as a valued partner in your care. As a final, crucial disclaimer, everything I have shared today constitutes general medical information grounded in published research and extensive clinical experience. Every individual's medical situation is uniquely complex. Therefore, before making any definitive decisions about surgery or treatment, please engage in a full, honest, and unhurried conversation with your personal doctor or specialist, as they possess your complete medical history and an intimate understanding of your body. It is in that informed, direct, and unpressured dialogue that the foundation of truly good medicine is laid.